and go.
Welcome everyone. Thank you for joining us at today's Lunch and Learn. My name's Andrew Fletcher. I'm one of the palliative medicine consultants in Central Lancashire. I'm the medical director at St Catherine's Hospice, and I'm the palliative end of life care clinical lead for the North West Coast Clinical Network. I'm sorry I'm not able to be with you for the actual session, but Debbie Harvey will hand over to in a little while. We'll be there to answer some questions. What I'm going to do is just start with a little bit of an introduction to the background to early. So next slide, please. So early's, I've said they've been developed over approximately 5 years. I think it may well be longer than that, maybe even 6 or 7 years. And it came out of a very small idea of thinking, how can we improve the identification of people in the last 12 months of life to support advanced care planning and now anticipatory clinical management planning. It's been a true collaboration, so there's been a lot of palliative care involvement and also primary care, and lots of primary care colleagues have undertaken several pilot studies to really think about how do we refine the search tool, refine the approach, and make sure that it really delivers in the way that we would want it to. We very much see this as being a tool to aid identification. It's not the whole solution. I think there's a lot of work that needs to wrap around this to ensure that we really have the impact that we're hoping for. Next slide, Kath. So just in terms of what we already know, and there's lots of different percentages that we can see in the evidence, but really around about 3/4 or 75% of deaths are expected or anticipated. And this is the group that we're really thinking about here, where there's a real opportunity, if we do identify these patients, to have in-depth discussions with them around their wishes and preferences and help them to plan for their future and for the end of their life. We think that really, in order to have these conversations effectively, you need about 12 months or so that you can actually give people time to consider what's important to them. We know more and more that some of these conversations seem to be quite reactive. So someone gets admitted to hospital unwell with sepsis or another cause for deterioration, and they're the triggers to try and have these conversations, but they're often not at a point where that person feels able to or is able to engage in those conversations. So doing them proactively really empowers that person to be involved and obviously engaging with their family when we can. We do know, and we recognise this, and this was one of the things that came through in lots of the pilot work, was that identifying patients with cancer who are potentially in the last 12 months of their life is fairly straightforward in a lot of situations, but it's much more complicated in people with chronic conditions like COPD, heart failure, where they have a very much a relapsing remitting type of approach of exacerbations, become less well, may improve, may not, but don't return to their baseline, or people with dementia and frailty, where it's a much more gradual trajectory and very difficult to predict at what point they're going to deteriorate and potentially enter the last weeks or potentially days of their life. Next slide, please. So why is this important? I think for me, what it should be about is giving people the opportunity to have these conversations and explain what's important to them to achieve their wishes and preferences at the end of their life. We know if these conversations are had, there's a much greater chance that people will achieve their preference to die out of hospital, for example, if that's one of their wishes. It is very much a voluntary offer. I think for us, it's about opening up those conversations. Patients may say to us, I actually don't want to have that discussion, and that's fine. We know we can obviously go back and revisit that with them at another stage. There are various elements of advanced care planning, so it can involve where someone wants to be cared for, who they want to look after them, who they want to be around. But I think we're talking more and more now about anticipatory clinical management planning, which very much sits alongside that advanced care planning, which is a real focus on what medical treatments would someone want and not want, and what medical treatments would and wouldn't be appropriate. So that could include, would they want antibiotics? And if they did, were they oral or intravenous antibiotics? How would we manage their seizures if they do have seizures at the end of their life? It would also include things like hospital admission or hospital avoidance. So the two things for me sit really closely together, but the fundamental part of this, we've got to identify these patients in order that we can trigger for having these conversations and supporting them with that future care planning. Next slide, please. There There are lots of tools out there. These are just a couple of examples. So there's the SPICT, which is the Scottish tools, and then there is the GSF proactive identification guidance. The trouble with some of these, although the information is really useful, is you need to keep these ideas in mind when you're seeing patients in order that you think, maybe I need to have these conversations. What we were trying to do with the early tool is to give people another way of identifying patients so they can actually have a list ready with names on. And then when they see those patients, actually kind of that can be the trigger for discussions. But I do think it's still really important that people have these indicators in their minds. So if they do just happen to be reviewing a patient in clinic or at home or in hospital, they kind of go, actually, I'm starting to see some of the things that might suggest their approach in the last year of their life. Maybe we need to start having some advanced care planning discussions. Next slide, Kath. When we developed early, we created an acronym for it that was to, I guess, give people a bit of an idea of what we would hope they would do with this. So firstly, it's around that early identification. So it's identifying patients who we think might be the last 12 months of life. From that, there will be conversations around their advanced care planning, their wishes and preferences. We need to make sure we record that information and share that information, which I know is practically quite tricky at times, but it's really important that we do all our best to ensure that information is shared with people involved in their care, because if other people don't know what the wishes and preferences are, it does make it more difficult for them to be achieved. Early for look again, which is the fact that this needs to be reviewed, and a conversation that someone has now will not necessarily be their same wishes and preferences in a few months' time. So they really need to look at that too. And then the other thing is about continually improving. So really thinking what experiences have patients and families had, doing mortality reviews, and trying to understand how we can make sure that we continually improve the experience for patients and their families. Next slide, please. So in terms of the early search, so there is the toolkit, which is where you will run a search within a GP clinical system. Most of the work can be done within EMIS, but the tool can be used within others such as System 1. It uses coding within those clinical systems, and that will be things like a disease, for example, COPD, heart failure, cancer, and then it will use some other markers such as number of admissions to hospital, and if people have had multiple admissions, that will again be a trigger for their inclusion. You then get a list at the end of that which outlines the patients and why they've triggered on the early tool, and that will be broken down by disease. But what we've really recognised, and I guess with the development of the tool, is that it's not perfect, and I don't think any tool can be perfect. It will identify patients that are not felt to be appropriate, and that's why we need this clinical validation to ensure that we are focusing the efforts on those that the tool has identified, but a clinician has gone in and said, actually, yes, I think they would really benefit from the opportunity to do some advanced care planning. Next slide, please, Carol. So like I said, very highly dependent on coding. We know from some of the work that, for example, it will pick up things like, it will pick up metastatic cancer, and obviously some metastatic cancers will have a very poor prognosis, but others can actually have a much longer prognosis. So people with breast cancer and bone metastases, but no other metastatic disease, can actually have quite a long prognosis, and therefore advanced care planning and end-of-life care discussions may not be appropriate. Other examples, I can pick people up with end-stage renal disease who are on the transplant waiting list. There are other examples such as it picks up liver cirrhosis, but obviously that could be a huge spectrum of illness from mild through to very severe, but it isn't able to necessarily separate those out, and that's where that clinical validation is really important. Next slide, please, Carol. And this final slide from me, and then I'll hand over to Debbie, was just to provide a bit of a structure for how to use this and how it can be applied into clinical practice. So the first step is the identification, and early being one of the ways of doing that. Then there's a clinical validation step, as we've discussed. Then the next step is, if that person's been identified and is appropriate, opening up those conversations with them about their wishes and preferences. If they decline to be involved, then we accept that that's their preference, but would want to really consider how we bring that discussion back to them at a later stage when they may feel able to engage further. Next step, if we do some advanced care planning, is how we share that information. So including that within the primary care record and sharing that with other clinical systems where we can. And then that final step being the review and the evaluation. So reviewing is making sure that we've revisited their wishes and preferences, addressed them, changed them if that's appropriate, but then also how we gain feedback, both in terms of patient and family experience, but also that mortality review where we look at did our intervention actually lead to a better outcome for that patient. So that's everything with me. So I'll hand over to Debbie now. Thank you.
Thanks, Andrew. So yeah, I'm Debbie Harvey. I work as a GP over in Bootle. I'm a portfolio GP, and one of my roles has been as the primary care lead for palliative end of life care in Cheshire, Merseyside. So just following on from Andrew's introduction of early, how can early actually support us in primary care? So it can support PCNs and the wider system. It can help us identify patients in all disease areas and when used alongside proactive identification during clinical contacts. And it can also help focus in discrete disease areas as well. Next slide. So this is what early will look like when you've done a search. So this was run in a practice where I work, and we have around 6,000 patients. And as you can see, the search identified 118 patients. Now that might feel utterly overwhelming, and we're very aware that people have limited capacity, particularly at the moment. Next slide. But those patients are really helpfully subdivided into disease areas within the search in EMIS. So as you can see there, there's a list of 8 different areas with differing numbers in each. Next slide. So how do we choose a disease area? There'll be lots of reasons why you might choose a disease area, but it may well be influenced by your capacity at your practice, because the patients, as Andrew has said, they need clinically validating. So it's important that it's a clinician who's actually looking at the patients. You might have disease areas of unmet need in your practice. There may be a specific disease group where you have high hospital conveyances, or you may feel that there's a group of patients in a particular disease area where you have low GSF registrations, and there may be other reasons as well. Next slide. So going back to our list, in the example here, we have 20 patients with COPD, and that list will need clinical validation. And the practice has chosen to look at these patients because it's already working on the clinical optimization of patients with COPD. Next slide. So what next? So as we have mentioned on a number of occasions already, clinical validation is absolutely essential. And the key question is, would you be surprised if that patient died in the next 12 months? And this kind of work doesn't have to happen in one day or a week, but it can be performed over a number of weeks or months according to clinical capacity. You then need to decide if it's appropriate to approach end-of-life care discussions, and if so, offer the opportunity to engage with that patient, their family and carers. And those conversations may then develop into planning, may include an advanced care plan, and there may be an anticipatory clinical management plan as well. Next slide. There are lots of other things that you might want to consider that might help you in deciding whether to approach particular patients beyond the 12-month question. So this long list of statements and questions is hopefully helpful just to provide some support with those decisions. So if we just look at a couple of these, so you may have patients who are attending the GP surgery. Even more, by attending, that may include contact. So you may be getting frequent telephone calls or home visits, or they may be presenting at the surgery. Patients may be having lots of encounters with the emergency services and out of hours. Quite often we look at 3 or more encounters over the past 6 months. And additionally, we could also look at admissions into hospital in the last 6 months and whether there's a particular pattern to those. Next slide. So just going to look at a patient example. This is entirely made up. So this person does not exist, but is based on quite a number of patients over the years. So we've identified John. He's in that list of patients with COPD. He's 77. He lives with his wife, who's 71, and he's been admitted on 3 occasions over a period of 16 weeks. He required ITU on one of those occasions for the treatment of pneumonia, and unfortunately also had acute kidney injury during that admission. So during that admission, the hospital agreed a DNAR order in the context of poor physical health and the fact that John was unlikely to survive resuscitation. However, there was no advanced care plan, no sort of similar discussions either. So, in addition to the admissions and what's happened over recent weeks, John has a BMI of 18. He's also got CKD and has an EGFR of 20. The poor man is now housebound and barely mobile at home, and he's also short of breath at rest. He's on maximum medication and he's been under the care of the respiratory team. So, looking at all that information in the clinical system, we approached John with respect to failing health and optimal appropriate care. And even John recognised himself the need for a different approach. And actually, he was fed up of going to hospital and feeling so ill. So there were detailed discussions with the family and patient. An advanced care plan was agreed. The respiratory team were also involved with referral to the district nurses. And as Andrew mentioned earlier, sharing this information is absolutely paramount. So we've also filled in the EPACS template, which will help with that sharing and coordination of care. Next slide. So what happened next? So John continued to live at home. He had carers 3 times a day. He received 2 courses of oral antibiotics for a chest infection, but unfortunately he continued to deteriorate. In accordance with the advanced care plan and the escalation treatment plan and his wishes, John was not transferred to hospital, and he received supportive care at home with the provision of symptom control medication. He died 7 weeks after the initial conversation regarding end-of-life care. Next slide. So some additional information about early. So instructions regarding uploading the search and running the search are available on the resources slide, which will come shortly. If you have any specific IT issues, please contact your local IT support provider, and any general inquiries can also be sent through to the team focused on early. We're also aware that localities, both locally and nationally, are exploring other IT solutions to identify people in the last year of life. And as Andrew mentioned before, there is no perfect tool. With that in mind, we do need to be really cautious that there are searches potentially which use data where either practices and or patients have decided to opt out of data sharing. So that's really important to recognise because it could exclude significant numbers of patients and actually compound inequalities. Next slide. So the early toolkit can be accessed using the QR code and the link there. And as we mentioned, the search is only one part of early and the other aspects of it are really, really important. Next slide. And the resources can be found on the NHS England website with a link there. And as mentioned before, if there are any queries, please contact the team via email. Next slide. Thanks for your attention and we'll take any questions. Thank you.